Also from my side, a very warm welcome to this excellent symposium, and it's a pleasure to be chairing this session together with Christian Hamm from Gießen and Bad Nauheim, Germany. And we have a very interesting controversy. What is your preferred anticoagulant agent in STEMI patients? And the choice is between unfractionated heparin and low molecular weight heparin. And Dr. Sanchis from Valencia will talk in favor of unfractionated heparin. I think we have roughly 10 to 12 minutes for each contribution, and then we will save some time for discussion at the end.
Good afternoon, everyone. First of all, I would like to thank the organizers for having me at this important meeting. I'm going to start the first controversy about what is the best anticoagulant agent in STEMI patients. This is the scenario in primary PCI in STEMI, an occluded coronary artery by red thrombus, then anticoagulation is mandatory. We have three options: heparin, enoxaparin, and bivalirudin, and my choice is heparin. This is a simple schema of the mechanisms from artery wall injury to the formation of red thrombus. There are two main pathways. On one hand, platelet activation, and on the other hand, the coagulation cascade. Focusing on the latter, thrombin plays a central role, producing fibrin and fueling platelet activation. Heparin is an indirect antithrombin agent because it requires a cofactor, antithrombin 3, and the resulting complex inhibits circulating thrombin. Enoxaparin is also an indirect agent, but its effects are against the factor 10A. And bivalirudin, in contrast, is a direct antithrombin agent with a triple effect against circulation thrombin, clot-bound thrombin, and also platelet activation. So conceptually, heparin has the less effective mechanism of action. It has the worst pharmacokinetic because there is a variable binding to plasma proteins, which makes its effects less predictable, and the need for ACT monitoring. Unlike enoxaparin, it has a weak inhibition of factor 10A, which might favor rebound ischemia after the interruption of the treatment. And unlike bivalirudin, it has no activity against clot-bound thrombin. However, and despite these theoretical limitations, heparin is largely the most used anticoagulant, and no trial has fully demonstrated the superiority of the other agents over heparin. Enoxaparin is an alternative to heparin. This pilot study on PCI patients demonstrated that after a single IV bolus, enoxaparin had a very rapid effect on 10A factor and short half-life without the need of anticoagulation monitoring. These properties make enoxaparin ideal for PCI procedures. The ATOL trial is the most important trial comparing enoxaparin and heparin in primary PCI. Around 1,000 patients with STEMI and indication of primary PCI were randomized to enoxaparin or heparin during the procedure. And this was the main endpoint, no differences in the main endpoint, including ischemic and bleeding events at 30 days. It's true that enoxaparin was superior in some secondary ischemic endpoints, but the study didn't have statistical power for these secondary endpoints. And there were no differences in bleeding events. This meta-analysis included all the studies comparing enoxaparin with heparin. And in the scenario primary PCI, enoxaparin was superior in terms of mortality, ischemic events, and bleeding events. However, this meta-analysis had important limitations because it included very heterogeneous studies. In fact, the ATOL trial was the only randomized trial in primary PCI. The remaining studies were registries, some of them with few patients, or post-hoc analysis of all trials where fibrinolysis was the main treatment and post-fibrinolysis PCI was considered. Bivalirudin is an alternative to heparin. This meta-analysis included 12 randomized trials comparing bivalirudin with heparin. In these trials, the asymmetrical distribution of GPI use makes the comparison between bivalirudin and heparin a bit confusing. Indeed, in those trials where bivalirudin was compared against the combination of heparin and GPI, then the bivalirudin arm had a lower risk of bleedings. But in those trials where, with a well-balanced distribution of GPI, there were no differences. The HIT PPCI trial compared bivalirudin and heparin in primary PCI. This trial reproduced quite well clinical practice. Little selection bias, radial access, low use of GPI, and the infusion of bivalirudin stopped at the end of the procedure. In this trial, there were no differences in bleeding events, but the use of bivalirudin was associated a higher risk of ischemic events, mainly driven because a higher rate of new myocardial infarction, in particular of stent thrombosis. The results of this trial raised the hypothesis that a prolongation of bivalirudin infusion could avoid this excess of stent thrombosis. This hypothesis was tested in the MATIS trial, which compared bivalirudin with heparin in acute coronary syndrome, but in addition, in the bivalirudin arm, patients were randomized to a prolongation of the infusion or not at the end of the procedure. The trial was neutral in the primary endpoint, combining ischemic and bleeding events. But again, in terms of stent thrombosis, the frequency was higher in the bivalirudin group, regardless of whether or not the infusion was prolonged at the end of the procedure. Interestingly, in this trial, patients were very well treated with dual antiplatelet therapy. Therefore, the excess of stent thrombosis seems to be linked to the use of bivalirudin. This is an intriguing question. Is it possible a tailored anticoagulation therapy according to ischemic bleeding risk? Primary PCI, by definition, is a high ischemic risk scenario, probably the highest ischemic risk scenario. Therefore, optimal antithrombotic strategy is mandatory, optimal antiplatelet therapy. In addition, should we routinely use enoxaparin rather than heparin? Sincerely, I don't believe so. I admit ATOL trial was a signal, but not robust information. And this is probably the best known bleeding score in primary PCI patients, although I think that another item should be added, patient under oral anticoagulation treatment. Provided we can identify patient at high risk of bleeding, how to avoid bleeding in this particular patient? Radial access, no GPI. In addition, should we routinely use bivalirudin rather than heparin? I think that we have some signals, but not robust information for this policy. What do most interventional cardiologists think? This is just my opinion. Enoxaparin may be slightly superior to heparin for preventing ischemic events, but this is not fully perceived nor translated into clinical practice. In addition, a more expensive drug than heparin. Bivalirudin may be some bleeding benefit, but perhaps not relevant using radial approach and low rate of GPI. Concern about stent thrombosis, and it's also a more expensive drug. And this thought is reflected in the guidelines. These are the European guidelines. Heparin recommendation 1, enoxaparin and bivalirudin recommendation 2A. It's true that the level of evidence is A for enoxaparin and bivalirudin, but this superior quality of evidence was not enough to convince the experts. And these are the Canadian guidelines that I'm showing here because they are the most recent guidelines. And again, a heparin strong recommendation, bivalirudin and enoxaparin weak recommendation. Again, the evidence has superior quality for bivalirudin and enoxaparin, but not enough to convince the experts. For all these reasons, my anticoagulant of choice in primary PCI is heparin. Thank you.
Yes, thank you very much, Dr. Sanchis. And we, I think, immediately go to the next talk, and then we get together and discuss or have our controversy. And that's Dr. Gómez from Barcelona here. A sunny town today, sunny city today, and he talks on low molecular weight heparins.
Okay. You can put my slides. First of all, I want to thank the organization, its invitation. I'm very, it's for me, it's a pleasure to be here in place of Dr. Montale-Scott. They put the title, they're moving now. And for family problems, Dr. Montale-Scott can come here, so I try to make a substitute of them. I think I try to, it's a change of opponent, so probably it will be easier for Dr. Sanchis. Okay, we are talking about the primary PCI, patients with STEMI. And we know that during the STEMI and the primary PCI, we have to put the patient with a pharmacotherapy previous to PCI. We are talking about the antiplatelet therapy, and we are talking now to the anticoagulant therapy, and we will talk about the enoxaparin. What about the background for the use of enoxaparin in PCI? So we talked with stable patients. The first study was the first randomized study was a STEEPLE trial that randomized more than 3,000 patients to 3 arms. They compared 2 different doses of intravenous enoxaparin, 0.5 milligram kilo, 0.75 milligram kilo, and comparing with an adjusted fraction of heparin with or without GP2B3A inhibitors. The primary endpoint was the safety endpoint, was major or minor bleeding, non-cabbage bleeding at 84 hours after PCI. As you can see on the top on the right, the ratio of bleeding was significantly less with the 0.5 milligram kilo from intravenous enoxaparin in front of fractionated heparin. There was a trend, but not significant, with a reduction of bleeding, also with 0.75 milligrams per kilo. One of the secondary endpoints was the percent of the patients that are reaching the target anticoagulation during PCI, but at the moment of the start or at the end of the procedure. As you can see in the top right and the bottom right, the patients that achieve these target anticoagulation levels are close to 80 to 90% with enoxaparin, and only less than 20% with fractionated heparin. And the other secondary endpoint was the ischemic events at 30 days. As you can see on the right, there is no difference between the three groups of enoxaparin, 0.5 milligram kilo, 0.75, or fractionated heparin. So it seems that the profile was safe for the enoxaparin during PCI in stable patients. And the literature assumed that 0.5 milligram kilo was the better dose for the treating patient with PCI. We remember that the half-time was 2 hours, so if the PCI lasts more than 2 hours, we have to remember that another additional bolus of enoxaparin, intravenous enoxaparin, has to be infused to the patient. What about enoxaparin to treat patients with STEMI? The first studies were in the setting of non-primary PCI. So this is a STRACT-TIMI 25 trial that randomized patients with STEMI less than 6 hours of evolution that were treated with thrombolytic therapy. They randomized patients to enoxaparin, with a dose that depends on the age of the patient and the clearance of creatinine, in front of unfractionated heparin with a bolus and infusion. The endpoint were first efficacy endpoint, death or non-fatal MI at 30 days, and the first primary endpoint with the safety endpoint was STEMI major hemorrhage. As you can see, there is a clear benefit in terms of reduction of ischemic events with enoxaparin in front of fractionated heparin. From the primary endpoint death of non-fatal MI at 30 days, even if there's death, non-fatal reinfarction, urgent revascularization by 30 days. And there are also another trials that test the enoxaparin in front of fractionated heparin, and this meta-analysis summarizes the results. There is a trend that is a decrease in the death at 30 days for those patients, and there's a clear benefit in terms of reinfarction at 30 days with the treatment with enoxaparin in front of unfractionated heparin. So they are moved to the primary PCI. We need data with STEMI patients treated with primary PCI. The first data were with a non-randomized fashion from the FINESS study. The FINESS study tried to demonstrate the feasibility or the safety and the efficacy of the pre-treatment, the facilitated PCI in the setting of acute myocardial infarction. This one first arm is a primary PCI that patient receiving the apixaban in lab. The second was facilitated primary PCI with apixaban in the first medical contact. And the third arm is half dose of Reteplas with apixaban in the first medical contact, and then to transfer the patient to primary PCI. The decision to treat the patient with low molecular weight heparin, enoxaparin, or unfractionated heparin was the decision for the physician. So there is not randomized in this setting. But we have several data. Remember, there is not a randomized comparison, but when we analyze the different events in this study, even the net clinical events, major bleeding, major adverse cardiac events on all death, there are a trend to be in favor from patients treated with enoxaparin. And we made a study, and there's a clear benefit with an odds ratio that's close to 0.6, with a less bleeding with enoxaparin, less death at 90 days, less death or ischemic events at 90 days. So with these results, they move to the ATOL trial. The ATOL trial was an interventional randomized study comparing in intravenous enoxaparin or intravenous unfractionated heparin in the setting of primary PCI. He conducted this study, and the randomization was as early as possible with the first medical contact. And they tried to do the real life population. There is no exclusion for shock patients with cardiac arrest patients. The only that we have to be sure is that no anticoagulation was administered before the randomization. And when we analyzed the study, the similar antiplatelet therapy was in both groups. So patients with acute myocardial infarction that was transferred for primary PCA were randomized to intravenous enoxaparin 0.5 milligrams kilo with or without GP2B3A inhibitors in comparison with intravenous and fractionated heparin with adjusting the dose depending on the use of GP2B3A inhibitors. Then we perform primary PCI and follow the patient with anticoagulation with subcutaneous enoxaparin, or in the arm of fractionated heparin, it can be followed by infusion of intravenous fractionated heparin or subcutaneous enoxaparin. The primary endpoint was death, complication of myocardial infarction, procedure failure, or major bleeding. This is a complex primary endpoint, and the complication of MI was defined as a resuscitated cardiac arrest during PCI, recurrent acute cardiac syndrome, urgent revascularization, stroke, peripheral or pulmonary embolism. And the procedure failure was defined as definite stent thrombosis, bailout use of 2B3A inhibitors via complications during the procedure, non-TIMI3 flow at the end of the procedure, or ester resolution less than 50% at the end after 30 minutes after the procedure. The secondary endpoint was death, recurrent MI or acute coronary syndrome, urgent revascularization. From this trial emerged two papers. The first paper was the main paper that is included all the patients that we are randomized as the intention to treat, and the second paper was 2 years after the first, and they analyzed the per protocol treatment, the treatment that was received the patient. And probably there are some difference. In comparison of both trials, in the second, there are 100 patients that received both heparins during the treatment, so they are excluded from the second trial, and there are patients that are randomized in one arm that receive finally the other treatment. So with this data, the primary endpoint, remember that was death, complication MI, procedure failure, or major bleeding. There's not significant difference, but a very important trend to have a benefit of those patients treated with enoxaparin in front of those patients treated with fractionated heparin. When we analyze per protocol treatment received, there are clear benefit with a significant reduction of this primary endpoint. When you analyze the main secondary endpoint, death, recurrent acute coronary syndrome of urgent revascularization, both trials showed a significant benefit from those patients treated with fractionated heparin. There is a reduction of 41% of the endpoint with intention to treat, and this difference was increased to 73% with the per protocol treatment. And we are talking with the safety of this treatment. The major bleeding was no difference with the intent to treat the population, and there is a very big difference, a significant difference with the safety profile from enoxaparin in front of the unfractionated heparin. Even if you analyze the secondary endpoint as all-cause mortality, there is a trend to be less in the group treated with enoxaparin, and when you analyze per protocol patient that the treatment received, there is a clear benefit, a significant benefit from those patients treated with enoxaparin. So this is the meta-analysis that Dr. Sanchis presented before. So there is a clear demonstration that in all PCIs, and especially in the setting of primary PCI, there is a clear benefit on the ischemic complication with death MI, complication of MI, with the benefit on the major bleeding, not benefit for the minor bleeding. And this last year, 2 years ago, we published an updated meta-analysis that showed in the effect of death, there is a trend that is a significant benefit from those patients. There are the results. Well, there are some studies that are randomized. There are other studies that are not randomized. The use of enoxaparin or fractionated heparin, and there is a trend, but not a significant difference in terms of major bleeding, in terms of safety. And even the same author of the ATOL trial, that is the group of Montal-Scott in Paris, presented the E-Paris registry, that was the patients that are treated for acute myocardial infarction in the area of Paris, And there is the rating to analyze the real life, and there is 518 patients with STEMI treated with primary PCI. They are treated with unfractionated heparin in front of patients that treated with enoxaparin. These are not randomized. There is a real life. And again, they demonstrated that there is a clear benefit on the ischemic events in death, reinfarction, or organ revascularization, with no differences in bleeding. In this case, there is not showed any difference in the safety profile. So, Dr. Sanchis presented before, there's the guidelines. It's very difficult to convince the experts, even with more evidence, the experts are not convinced, but they increased the recommendation for enoxaparin, passed from 2B to 2A, and with so Dr. Sanchis presented, even with the evidence with A class, they are not convinced the experts, and they are 2A recommendation for the use for enoxaparin in front of 1C for the unfractionated heparin. If you use enoxaparin in a STEMI patient with primary PCI, you have to make, before PCI, a bolus of 0.5 milligrams kilo intravenous or intraarterial sheet at the first medical contact or into the lab. If the PCI is not finished 2 hours later, a second bolus, half of the first, 2.25 milligrams kilo. And the third is continuous with enoxaparin with a low dose, 40 milligrams subcutaneous once a day, starting right after the procedure and during hospital stay. It's difficult to understand this third option, but this is the right trial that are testing this hypothesis. And the right trial is including patients now. His sponsor is a Chinese hospital, and the collaborator the Chinese Academy and the action group from Paris. And they tested the hypothesis that we need to prolong the anticoagulation after the procedure, and the prolonged anticoagulation can be with infractional heparin with a low dose, and enoxaparin or bivalirudin in comparison with no anticoagulation. Here you have, there are close to 3,000 patients. The primary efficacy endpoint was ischemic events, and primary safety endpoint was major bleeding. So the results from this trial will be available in December of this year. So for conclude this presentation, enoxaparin can be used in all MI and all PCI patients. The single dose of intravenous 0.5 milligram kilo, they don't need 2 ACT monitoring. They will not change the dose with or without GP3A inhibitors, and they are demonstrated better safety and efficacy than unfractionated heparin. Thank you for your attention.
Thank you very much. Would you like to join us at the table? Are there any questions, remarks from the audience? Can see one over there.
I think there are many fans of heparin in the audience, but we need strong evidence to convince not only the task force members, but also the community. So I think these studies have been performed in a period of time where the penetrance of newer thienopyridines was not so high. The use of fondaparinux, that is enforced by the guidelines because it has the best balance between bleeding and prevention of recurrent events after PCI for ACS, was not ubiquitary. So I think you need a solid comparator, so you need to give, after heparin, also fondaparinux, and also put all the patients on the newer thienopyridines, so conduct a new study, and then we'll agree with you.
Yes, but they need some these studies, no? I think the profile from anticoagulation from enoxaparin is quite good. It is safe, and it is more stable than the other data, no? It's probably, I think during PCI it's quite safe. They don't change the dose. Probably, I don't know exactly, we have to wait for the results if they need to prolong this anticoagulation after the PCI, no?
I have a simple question regarding the unfractionated heparin. What loading dose are we giving today? Because usually it's said 50 to 70 units per kilo if no GPI is administered, and 70 to 100 if one is administered. But GPIs have moved to the bailout situation. Are many people giving only 50 units per kilo? I wonder. And a second thing I wonder is, what about the ideal ACT? Everybody or every cath lab has a value, like a sacred limit we need to reach. Whereas if I look at the literature over the years, it's all very vague and very unclear to me with what the ideal ACT during PCI might be. And should it be different in STEMI patients than in elective cases or whatever?
Well, at least in my lab, we use 7 milligrams per kilo as bolus of heparin. Regarding ACT, it's true that there is no robust information about if ACT monitoring is needed. And even the best information we have is that it is advisable a value above 300 milliseconds to avoid ischemic events. But in terms of bleeding events, it is not fully clear that we need ACT monitoring.
Yes, maybe, unfortunately we have to close. I mean, we are running out of time, but I would like to see a vote who is using unfractionated heparin and who's using low molecular weight heparin. So please raise your hand if you use unfractionated heparin routinely. Okay, the other, who's using enoxaparin routinely? So clear the majority.
The problem is that I don't know why, because
yeah, it's puzzling. I mean, I'm more confused than ever. Yes,
the trial is quite promising. So, so it's a pity of trial because the p-value was 0.06.
There are so many arguments for enoxaparin. That's difficult to understand that we still use this dirty drug from China, but it's working somehow, and it's convinced all of us. Because maybe it's low cost and it's better, can be controlled. We can measure ACT that gives some, safety, and we can antagonize it nicely, and so that's why we feel better. But you have the last word.
I don't know. I think probably one is the price. Probably there's a comparison of the price. It's different one from the other, and there's not a robust information. So probably we try to be very conservative in this issue. But also the another question is that I cannot monitorize the data. Probably they don't need to monitorize the effect of enoxaparin, but always be working with nothing exactly what are we doing. Probably it's easier to work with an ACT more than, I check an ACT, is 290. I'm comfortable with the situation. But with enoxaparin, we don't know anything. So sometimes it's very stressing to don't know exactly what is. And if you have a thrombotic complication during this PCI, it's very complex what to do. No?
Yeah, it's one of these strange scenarios in cardiology, so we cannot solve it today. And thanks very much. I think we had very good facts, and we have to continue to the next session.